Well, good morning. Like Maria said, I'm Amanda Gaddy. I'm actually a graduate of the University of Georgia College of Pharmacy. I graduated a few years ago, probably before you guys were born. And so I've had a really exciting career in pharmacy, very diverse background, always looking for opportunities to learn more, ultimately helping patients at the end of the day. And so over the next 45 minutes or so, I want to share with you some of the things that are really quite exciting in the world of pharmacy. We want to talk to you about why we're seeing a transition in pharmacy, away from just thinking about filling a prescription to taking care of the patient, and how this could impact you as when you graduate. Maybe some of the opportunities that you haven't thought about that are actually there, or maybe you can come up with your own. So let's get started. So before I tell you what I know, I want to know, this is the interactive part, maybe what you already know. So if you hear opportunities beyond dispensing or services beyond dispensing, thinking about like a community pharmacy, what comes to mind? You can just yell it out. Absolutely. Immunizations. What else? MTM. So you have been exposed. And also wanted to know is what changes are you seeing? I mean, you guys have been doing rotations in community pharmacies. Are you seeing the role of the pharmacist change at all? Or the role of the technicians change in any way? Interactive part. Maybe not. Okay. Well, and this is a really important question I want to ask, because you really need to think about this. Do you think that community pharmacists are working at the top of their licenses? Think about all the schooling that you've had. I mean, you are truly experts. And when you get into the community setting, maybe it's at a chain or an independent, do you really feel like the pharmacists are able to utilize all that knowledge to the top of their license and help patients with outcomes? It's not a trick question. I personally think not. I think that a lot of times you graduate, you get into this dispensing mode, and it's all about dispensing fast, accurate, cheap, which dispensing is very important. We want the patient to get the right medication, but we also want to think of you're experts. And so we want to make sure that you're using the knowledge, everything that you've learned to make sure that you're working at the top of your license. And a lot of the things that we're going to talk about today are those services where you are working at the top of your license. So why do we need to rethink the role of the pharmacist? Again, you can answer. Anybody know? Anybody know about anything that's changing? Well, we're actually changing, and this is healthcare in general. This is just not pharmacy. We're changing from, there's a transition from being reimbursed fee-for-service to a reimbursed based on the value. It's a value-based reimbursement. It's on outcomes. Is the patient getting better? Are they taking their medication? Were you guys aware of that? That that's actually a real thing? Yeah, it's a big thing. And this is generated or really driven by CMS, because CMS is the largest payer. And so CMS has said, hey, you know what? As a country, we're spending more than any other country, and our outcomes are worse than any other country, or at the bottom three probably. So something's got to change. We've got to stop paying per lab test or per procedure, and we need to hold people accountable for how these patients actually do, because outcomes do matter, and all healthcare providers are being measured. All healthcare providers. It's not just for pharmacy, hospitals, physicians, PAs, nurse practitioners, and we're really required to do more for less. And so that's whenever you're thinking, okay, we've got to figure out we can't stop the change, and the change is actually good. We should be held accountable for helping patients get better. And those who do a really good job incentivize, and those who don't penalize. But right now we're in this transition where pharmacies are required to do more with less. Some pharmacies are becoming non-preferred networks, which means that they're not preferred for those patients in the community, so they're losing patients. And believe it or not, they're getting paid less than before, so they're paying more for the medications and their reimbursements less. So that's a real issue. So let's talk about how hospitals and clinicians are impacted with this transition that we're seeing in healthcare. Hospitals have something called a hospital readmission reduction program. And this is where if patients are readmitted within 30 days for certain procedures or health conditions, they're actually penalized. They're penalized on all their Medicare patients the next year, often up to 3% of a penalty for payments. That's a lot of money when you're talking about how many patients with Medicare go through the hospital system. So think again, how does pharmacy fit in? How can pharmacy help prevent readmissions? And we'll talk about that in just a minute. Clinicians, doctors, PAs, nurse practitioners, they're now subject to their payment being decreased under something called MACRA. MACRA it's a quality payment program. And there are basically two paths with MACRA. There's NIPS, which is the merit-based incentive payment system, and there are performance categories within that, and then the alternative payment model. This actually just started this year, January, so this is new. But now physicians, nurse practitioners, PAs, they are now being subjected to performance measurements. And one of the big measurements has to do with adherence. How well is the patient taking their medication? Are they taking it like they're supposed to? And that's going to impact their payment. So now all of a sudden, it's not just write a prescription and let the patient go. We need to make sure there's follow through. Again, partnering with the pharmacy, the local pharmacy. So let's talk about how pharmacies are impacted with this transition. Anybody heard of star ratings? Yeah. Well, star ratings are actually where the Medicare Part D plans are rated, and based on the ratings, they can if they get a 5-star, then patients can transition in and out of their program at any time. So that's just one of the advantages. But a lot of their measurements for the star ratings have to do with what happens in the pharmacy. So the pharmacy can control a lot of things. And so now the Part D plans are saying, hey, pharmacies, now we're going to measure you. And we're going to hold you accountable. Well, we're going to push out, somebody said MTMs earlier, they can push out an MTM, which means we want you to sit down with this patient and do a complete medication review or CMR. We're going to pay you for that. Now, if you choose not to do it, we're going to penalize you for it. And that's where we're going to talk about the DIR fees. But they also push cases to them about adherence. So if a Part D plan sees that a patient's not taking their medication, they may send that to the assignment case to the pharmacy, and if the pharmacy can get them compliant, then they get paid $10, $15. But it is an incentive to help them with their measurements. The DIR fees. Anybody heard DIR fees? Okay, so this is a fee that is assessed after the point. So let's say prescriptions are filled in January. The Medicare Part D plans will come back in June, July, and they actually take money back from the pharmacy. Okay, it depends on the plan. Each Part D plan does it a little differently. Some say we're going to take back between 5% and 8% of what we paid you originally. 5% if you're really good, 8% if you're not so good. And that's based on those performance measurements. How well are you keeping your patients adherent? Are you getting your elderly patients off of Ambien? All of those things that are the measurement pieces. And so it's so important when you're in a community pharmacy to think about the services that you can provide that can impact your performance so that you can decrease the impact of something like a penalty of a DIR fee. So we've talked about transitioning. We're going from just paying for a prescription, paying for a service, paying for a lab, to how's the patient going to do? What's their outcome? Are they getting better? And there are some challenges with that, just like we just talked about. But the common denominator with all healthcare providers that are being measured is that patient. So that patient is the same patient that's going to the pharmacy, that's going to the hospital, that's seeing the doctor. And that's where I want you to think about the pharmacy, okay? So the community pharmacy can almost be like a care coordinator. And this is where it's so important to communicate with those other healthcare providers in the community. Because the community pharmacist sees the patient more often than any other healthcare provider. They're accessible. I mean, think about it. You don't have to wait 2 weeks to talk to the pharmacist. You can just call and talk to your pharmacist. They're trusted, y'all. That's huge. I mean, because when you're talking about improvement outcomes, it is so important that you have the influence on those patients. And if it's me and my pharmacist is telling me how important it is to eat right or exercise, it's probably going to be more impactful than if I hear it from some call center nurse. And knowledgeable. I mean, you guys are experts when it comes to medication. You know a lot. And at the end of the day, you truly can impact their outcomes in how well they do with their disease state. So, opportunities beyond dispensing. Now, I've told you about how wonderful you are, how you're trusted, you're accessible, you're knowledgeable. So what can you do with it? Well, one thing is chronic care management, and this again was spearheaded from CMS. What they want to do is figure out which of these patients have the chronic conditions that are driving up healthcare costs, and then track them on a monthly basis. So this is a billable service. Pharmacists don't bill directly for it, but they can work in collaboration with providers and provide, it's up to 20-minute monthly calls, and it really is, that check-in, how are you doing, how's your blood sugar, referring back as needed. But it is a way to have that contact with the patient. The pharmacist can do it in collaboration with a physician. The Meds to Beds program. This is where a pharmacist actually provides the medications to the patient prior to discharge. If you've worked in a pharmacy, and this has happened to me, a patient's been discharged after having like a heart attack. They have a stack full of prescriptions. It's Friday afternoon at 5 o'clock. We need PAs. There's duplicate therapy. I can't find anybody at the hospital to help. That's a breakdown in our system, and that could end up being a readmission. So working with a pharmacy in a hospital, and the pharmacy providing these medications ever before the patient leaves the hospital will definitely improve outcomes and decrease readmissions. Because the pharmacy will have a chance to do authorizations, do medication reconciliation, everything all those steps that need to take place so that we can ensure that patient is clear on their medications and that they're going to take them. Because how many times do you think that patients are discharged, don't feel great, and just like, I'm just going to go home and I'll deal with my prescriptions tomorrow or the next day. So we're ensuring with the Meds to Beds program that the patient's going to get their medicine. And from a pharmacy standpoint, you're basically getting referrals and hopefully retaining those patients going forward. Transitions of care. This is a program that, and it's billable through, pharmacists don't bill directly, but they can work in collaboration again with the healthcare providers. And basically when that patient is discharged, we need to follow to make sure that they circle back with their primary care physician, that there's follow-up phone calls, because we don't want them to be readmitted within 30 days or that could be a penalty to the hospital. And then 340B contract pharmacy. So 340B is a federal program that requires drug manufacturers to provide a discount to certain entities, like not-for-profit hospitals, clinics. So basically the pharmacy can act as an agent to that entity and fill prescriptions on their behalf. So the pharmacy is still paid based on their contracted rate, but the hospital or the clinic is able to order that product at a deep discount and ship it back to the pharmacy. So this results in revenue that the pharmacy passes to the covered entity. Now, from a pharmacy standpoint, they negotiate a fee for each claim that is 340B, and that fee is going to be more than they would make without 340B. So that increase in profit allows them to provide some of the other services that they may not be able to provide otherwise that could help keep the patients adherent and out of the hospital. Anybody worked in a pharmacy that did a MedSync program? So this is not all our refill, okay? It's not just, okay, we're going to sync all the medicine for one day and we're just going to fill it. Clinical MedSync is a proactive phone call to the patient 3 to 5 days before their prescriptions are ready. This says, hey, Mrs. Smith, we're getting ready to refill your prescriptions. Here's a list of what we have. Let's do. Does that match what you need? That's a very important question to ask because Mrs. Smith may say, well, I don't need my metformin. I haven't been taking it. It makes my stomach hurt. Well, that could be a problem. If that proactive phone call would not have taken place, the pharmacy would not have filled it. They wouldn't know she's not taking it because that conversation had not been had. Patient could go back to the doctor in 6 months to a year, had not been on the metformin the entire time, and now on insulin. So it also is a great way to do to ensure adherence, which again, pharmacies are measured on adherence, physicians are measured on adherence, and hospital readmissions occur most often because of non-adherence. So that's a very important program. Now, it's not billable, so a pharmacy's not going to bill for it, but it's going to indirectly improve their performance so that their penalties are less. Going hand in hand with this is adherence or compliance packaging, which a lot of pharmacies do charge for. They can charge like up to $20 per month. This is where they, if a patient's on a lot of medications, they basically bubble pack it. And so you have like morning, noon, evening. And I don't know about you, but if it were my parents and they were on 10 medications, I'd feel better about them getting the packaging so they could see clearly, have I taken my meds this morning? Or have I not taken them? Then depending on them going through the little vials and keeping up with it. Or even worse, true story, my father-in-law had one of the plastic organizers. He's over there just putting all the little, and he drops it. So then we have to go through and try to figure out which one goes with which, and it was just a nightmare. So again, adherence compliance packaging, it is something you can bill for, but it does help adherence, and again, it helps the patient. Somebody mentioned immunizations. It's another way to diversify revenue, differentiate the pharmacy. You can even work with, to do like a work site, like work with an employer and go in and do all the employees for an employer. That can give you exposure at the pharmacy and hopefully get some more customers to come to the pharmacy. Clean wave testing, this is like doing A1C checks, cholesterol checks. Those are being done in the pharmacy. And so as part of that patient care team, the pharmacy can communicate the results back with the providers, and again, helping to ensure that that patient is getting the best care possible. Some pharmacies offer weight management programs. This can be a cash base where you can actually charge the patient. Some self-insured employers will cover the cost for their patients. Again, it comes down to that communication piece of talking to the people in the area, if it's a self-insured employer, find out what they need, and this may be something they'd want to compensate the pharmacy for. And tobacco cessation, the same thing. So there's diabetes prevention program. This is something fairly new, and number one is it's kind of like a health care coach or a lifestyle coach. It does not have to be performed by pharmacists, but it can be, or it can be a tech, but it can be performed in the pharmacy. So you can bring people from the community to the pharmacy. What it's doing is it's identifying patients who are at risk of developing diabetes before they actually have diabetes. And so the hope is that we can change the lifestyle so they never develop diabetes, because as you know, diabetes is a very expensive healthcare condition. There is a training process that you go through, and then it's offered in group settings. I think there are like 12 sessions in 6 months, and then 3 the second 6 months, but you're paid based on how many patients attend. I think it's around $15 per patient. But if those patients meet their goals, like weight loss, then it's an extra bonus of like $50. So it's definitely a way that you can promote, again, differentiate your pharmacy, go out to the community, to the providers in the community, let them know that you're offering these classes, and be able to get compensated for it. And that's a direct bill. Diabetes self-management education. This is after the patient's been diagnosed. So the pharmacy goes through a process to be accredited, to be able to offer these services. But again, it's group setting, or it could be one-on-one, depending on the situation with the patient. There's payment made directly to the pharmacy for this. You have to have a referral from the physician. So this is a great way to go out and talk to the providers in the area and say, hey, we're doing diabetes self-management education. So if you have your patients when they're first diagnosed, if you send them or refer them to us, we will take care of them. We'll make sure they understand, the lifestyle that they need to adhere to, their glucose monitors, all the things that they need right away with diabetes, because as you know, diabetes can go out of control quickly if it's not managed. A billable service by the pharmacy. Disease state management. So a lot of self-insured employers will look at which of their employees are driving up their healthcare costs. Because if they're self-insured, they're paying everything, right? So if they can get those employees that are driving up healthcare and get them locked into a pharmacy to provide diabetes management, follow up with them every month, what's your A1C, what are you eating, then they can definitely decrease their overall healthcare costs. So the prescription part of it's only a little piece, it's about 10% of total healthcare costs. But the pharmacy can impact that other 90% through some of these interventions and these, such as the disease state management programs. The same thing as with payer contracts. Some pharmacies are actually working directly with Medicaid, commercial plans, and figuring out which of those patients are costing the most and coming up with the programs to help with outcomes. And then we have the opioid projects. So there's one that the pharmacists have available right now where they can actually go through and see who's at risk for an opioid overdose. They can sit down and do a consultation with the family or the patient and get paid for it. So a lot of this is about documentation. If they actually dispense a prescription, they can be reimbursed for that as well. So, and that's one that's recently come out based on the opioid epidemic. So you may be saying, well, that's all great, but like, how do we do it? Like, how does we document it? And there's something called the Pharmacy E-Care Plan. Has anybody heard of this? Okay, so basically it's a standardized way of collecting data, and it's along with the pharmacist patient care process. I'm sure you're familiar with that, right? Yeah. When I was in school a million years ago, that was so, you know. But yeah, so it's aligned with that. So it's standard no matter which platform has it. But it's a way that when you document all the things that you're doing for that patient, that you can bill for it to a payer, or you can exchange it with a hospital or with a physician. And it basically does, you know, what are the patient goals, the concerns, the therapy problems, interventions. It's all in a standard way, and that's the key, is that it's in a standard format that can be shared between other health stakeholders. I mean, how many times have you been in a pharmacy and somebody's just faxing stuff, and then you have to manually enter it in? So this is a new thing, fairly new thing, where it's a way that you can document, bill, and share. And I have this on here, the sky's the limit, but I really think that, because, I mean, you're going to graduate soon, and how exciting you have so many options in the world of pharmacy, but just be open to creating opportunities. You know, if you're coming at it with a fresh look. I've got 25 years of experience that allows kind of what I do, but you know, when you're in a practice setting, no matter which practice setting it is, if there are issues or obstacles, think about like, what solution can I do, or what opportunity is this? Like, how do we make this better? And communication with other clinicians is critical, because for so long we've been all in silos. I'm doing my thing, you're doing your thing. But if we can talk about Mrs. Smith, our patient, who we all share, then Mrs. Smith's going to have better outcomes. And we're probably going to get penalized less, and hopefully incentivized more, because we're going to help her do better. And again, just think outside the box. What can you do differently? But always keeping the patient at the center. And that's true. I know sometimes it can be frustrating. You've all had rotations, you probably had those customers, but you know, I just remember I had this real frustrating customer when I first graduated. I was at a real busy retail store. I was at Kroger, and I was talking to my mom about it. She was like, just imagine if that was your grandmother. You know, wouldn't you want to have an extra level of patience with her? And I know that has nothing to do with clinical services, but I think it's a real important point to make of really just keeping that patient at the center, and knowing that there's somebody's grandmother, or sister, or daughter, or whatever. So, Harry, that's all I have. You want to just ask questions, take questions? Okay. Questions?
What questions do you all have?
Or comments. What do you think? I really want to hear from you. Like, I'm not here just to stand in front of you. I really want to hear, like, what do you think about this? Like.
So, just a concern that I've heard from other pharmacists is that as the role of the pharmacist expands, and you know, obviously we have the requisite knowledge and everything that we need, but a lot of pharmacists are worried that you know, we already have our hands full of responsibilities. So as the role of the pharmacist continue to expand, how do you think we as a profession what should we do to combat possibly getting overloaded with too many responsibilities and obligations?
That's a great question statement. I mean, and that's what I hear day in and day out. And we were actually talking about this earlier this morning, is that's really kind of where data comes in, you know, where we can track data and say, okay, you may have to hire a part-time pharmacist right now, but what's the return on investment going to be? Like, is it going to, will your DIR fees go down enough to support that? Also, utilizing the technicians. I don't think that we utilize the technicians the way that we should. With NTMs, I have some pharmacists that say, well, I don't have time for NTMs, but truthfully, technicians can do about 70%. 70% of the stuff is like non-clinical. You know, it's only that clinical part that you need to pull the pharmacist in. So training technicians, having like it into the workflow is key. But I mean, it is you're right, it's an obstacle. Because I mean, they're just like busy filling and busy losing, let's be honest. I mean, they're losing money on prescriptions. It's frustrating. It really is, and that's why one thing I didn't mention here is, but like just doing like supplements. You know, somebody gets a statin, making sure they get CoQ10 as well. That's good service. That's good patient care, but it also is a revenue source. But you're right. It is an issue. I mean, I would just say overall, you know, utilize the technicians, tracking data, seeing what that return is at the end of the day. Because I can tell you, the pharmacy owners that I work with that are doing these services, they're financially better off than the ones who aren't.
So I'm pressing this button just to ensure that the other campuses are hearing me. Are you hearing me, other campuses?
Yes, sir.
Wonderful. You know, what was your name? Addison. Addison, I am so glad you asked that question because lo and behold, you all have an option in your group project to address that exact issue. You know, a lot of pharmacists I talk to say also, I'm hearing the same thing. You know, we just don't have the time and resources to do it, right? Well, you know, I'm putting it on you all to come up with these innovative strategies to rearrange the infrastructure of the pharmacy. Be able to utilize the resources that are available to enable pharmacies to expand their services, to do these innovative services, okay? So if you all look in your group project, option number 2 deals with, hey, what is it going to take for us to re-innovate the pharmacy setting, which will allow pharmacists to do some more of these advanced services. So thank you, Addison.
Another thing I didn't talk about, but pharmacists are actually going into physician offices and doing helping with Medicare wellness visits and doing the chronic care management, diabetes education. And that is almost like creating your own opportunity, you know, that conversation of, hey, what do you need, doc? Oh, guess what? I can do that. What other questions or comments or thoughts or? I mean, do you feel like that with your education that you feel equipped to provide these services in a community setting? Yeah, I think it goes back to Addison, like having the time to do it or having it into the workflow. Or even, again, creating the opportunity. Yes.
Hey, this is Summer in Savannah. I feel like a lot of students or students that work in independent pharmacies, they would love to do these opportunities, but it's kind of like, how do you find a physician that trusts you enough to implement these services? And then when you're putting in all the work to implement these services, you're not getting paid for it. So it kind of is like you're putting in extra work and then not getting any reimbursement. So what do you think about that?
Can you be a little bit more specific about which services that would be that you're, because there are programs that you can get paid, like if you're helping with chronic care management or wellness visits or diabetes education.
I guess kind of just like, how do you develop a relationship with a physician enough for them to trust you to like go into their office and do things like that, do pharmacotherapy appointments with the patients?
Great question, Summer. And I think it goes back to the second bullet point there. Communication with other clinicians is critical. So it is having those conversations, meeting for coffee, saying, hey, we're all being impacted here. And I've been in these meetings before with hospital, the CEO, the CFO, in the local pharmacies to say, what are you experiencing? Well, we've got $21 million of uncompensated care. Or we've got readmissions, and it's mostly asthma related. Well, what can the local pharmacies do to help with that? And it happens, but it's that collaboration, this communication, so that with time they'll feel comfortable and confident that you can help with those. Because a lot of times I tell independents specifically, like the people in your community, they don't know what they don't know. You got to tell them, and it's okay to promote yourself. It's okay to go out and say, you know, here's why we're different. You know, sometimes I think owners are like, well, I don't want to market, you know, I want to do healthcare. Well, they need the physicians and the hospitals, they need pharmacies that provide the services. Because again, they're impacted now with the measurements. And so I think that conversation, that communication, the here's what we do, here's how we do it for the services that we provide will most definitely open up the channels for the opportunity to work with physicians. And it's happening.
I have another question, Savannah. I have a question, Savannah.
Sure.
So, once you get the collaboration set up, you have, I imagine there are a lot of upfront costs, like you have to buy the software to submit the claims and do all the billing stuff, and then are there any legal requirements as to where you can have these consultations? Like, do you have to build an office type setting, or can you do it right in the pharmacy with like a partition? Just kind of, what do you need to pay for upfront in order to get this set up?
So, great question. It depends on the service. So, the wellness visits with Medicare, they have to be done at the physician's office. But chronic care management can be done off-site. So a pharmacy can do a lot of the services for that, and that can even just be a phone call. So it really depends on the service that's being provided. So for diabetes prevention programs, you could do that at a church or at a community center. You know, I mean, it doesn't have to be at a pharmacy. So I don't think it's as strict as far as that. As far as the upfront cost, right now we've been very lucky because the Department of Public Health has a lot of grant money that they're helping fund the software that the pharmacies are using to track and to track the data. So right now we haven't had that to be an issue, but I would say probably it's going to be about $300 a month. I mean, how comfortable are you guys going into pharmacies that you're on rotation and let's say you go to an independent and they're not doing any of these? Like going in and saying, hey, I can help you get this started. Or doing screenings, or, you know, like doing like A1C screenings, or if you had that opportunity, what do you think? I think I would have loved something like that when I was in school because, you know, but it was a different time. We were strictly, that was just when counseling basically became mandatory. For that, you didn't have to counsel the patient on the medicine. So a lot's changed, but I think just getting that full picture of how the patient's doing and monitoring would be cool.
I have another question in Augusta.
Okay.
This is more just getting your opinion on the STARS program. I work with pharmacists. I know this is more of like a legislative issue, but I work with pharmacists who are upset with the fact that it's penalizing us instead of the patient. So if a patient isn't, you know, coordinating with their doctors and really caring about their health, why is their health insurance still valid and covering their costs? And so it's hurting us instead of the patient who is technically responsible for these issues.
Yeah, that's a great comment. I hear that a lot. Because really, you can't go and make somebody take their medication. I've actually worked with pharmacies before that if patients wouldn't take their medications, that they basically fire them. They're like, we can't fill your prescriptions if you can't take them the way they're prescribed. But the way that, I guess, that CMS, their comment is, well, we're measuring pharmacies the same way. So if you're having that issue, so are other pharmacies. So just don't have it as often. I don't know. I mean, it's not a perfect system for sure, but it is the way that they're moving towards trying to improve the adherence.
Can I follow up on that? Can I follow up on that question? So when these pharmacists come to you and ask you, or they make comments about it's the patient and it's the patient's fault and why are we getting penalized? What are these pharmacists doing to help patients use their medications safely and appropriately?
So usually it's after like completing a CMR and the patient just admits to the fact that they're really bad about taking their medication. And so the comments I've really heard would be that this program would be more efficacious if their prescriptions, if they stop taking them or something, if they, if their coverage change or if their doctor's appointments change, because then the patient would understand the importance of being adherent.
So did those pharmacists try to address that adherence? And they're saying, we've tried everything that we can do to help this patient be adherent, and nothing's working, we just need to fire them?
Yeah, I have seen them quote unquote fire patients, but then they've talked about how some patients, if their medications were really expensive and they were covered, it kind of stings because now we're losing money because we've lost the patient.
Well, and I think just addressing the issue, I mean, for real, like, is it that they can't get there and pick it up, or is it that it hurts their stomach? I mean, asking the right questions is critical. I mean, because if you can uncover, well, I don't like taking it because it makes me feel dizzy, well, that's something you can address. So I think and going back to earlier about being trusted, if they have a real good relationship with the pharmacy and they trust the pharmacist, then they're probably going to be able to get to the bottom of it through that motivational interviewing.
So I just have to come back. I'm not an advocate for blaming the patient. In fact, I'm more of an advocate of, can we identify those underlying barriers that are preventing patients to be adherent to their medications, and let's help them address them. And let's not just do one try. It might take 2 or 3 times to help a patient use their medication safely and appropriately. So I just need to put in that disclaimer.
Other questions, comments? All right. Well, thank you for your attention.
Thank you all so much. We will see you all on Wednesday, where we'll have a concrete example of pharmacy service that are implemented in community to address the opioid epidemic. See you on Wednesday. Thank you.